Hello, thank you for coming to my talk. Today I'm going to be talking about patterns of sexual and other forms of violence during the COVID-19 pandemic in Kenya. Just a bit of information about myself. I'm a second-year PhD student at the University of Birmingham. I'm doing a psychology PhD and I'm split between the School of Psychology and the medical school. Today I'm going to be talking about the background information of our study, the goals of our research, our data collection process, our data analysis process, our findings, our recommendations, and our outputs. Just to give some background on sexual violence around the world, it is a public health and human rights problem with both short and long-term health and economic consequences. There are huge numbers of women and girls worldwide, as well as men and boys, who have been victims of sexual violence. They have been forced to engage in sexual acts or have been trafficked. And unfortunately, it is hard to get accurate numbers because sexual violence is one of the most underreported crimes around the world. Just to give some information about Kenya, which is where our research took place, Kenya is a country in East Africa. It ranks 147th out of 189 on the Gender Inequality Index. The Gender Inequality Index measures gender inequalities in three key areas of human development: reproductive health, which is measured by maternal mortality ratio and adolescent birth rates; empowerment, which is measured by the proportion of parliamentary seats occupied by females and the proportion of adult females and males aged 25 years and older with at least some secondary education; and economic status, which is described as the labor market participation and measured by labor force participation rate of female and male populations aged 15 and older. Over 11 million women in Kenya have experienced sexual violence as children and/or adults. Survivors infrequently report rape to the police, and when they do, they are rarely successfully prosecuted. As previously mentioned, rape is the most highly underreported crime in Kenya. It is estimated that only 1 out of 20 women in Kenya will report a rape, and only 1 in 6 will seek medical assistance. The COVID situation in Kenya became formal in March of 2020 when the government announced the first COVID case. Lockdown followed soon after and included a strictly enforced curfew and closure of schools, restaurants, and non-essential businesses. Soon after lockdown was enforced, violence between police and citizens occurred publicly, and sexual violence occurred privately. In fact, 15 people were killed by the police in Kenya in the first 9 weeks of curfew. There are multiple steps that survivors go through when reporting sexual violence in Kenya. You can see on this chart on the right that the sexual violence takes place, and there are multiple steps that they must go through in order to attempt to get the case submitted for legal proceedings. Survivors may face financial barriers at multiple points throughout the process. And also, some survivors and the families of their perpetrators choose to pursue customary structures such as talking to tribal chiefs instead of going the more formal route. Only 4 out of 10,000 women who were treated for sexual violence at the Nairobi Women's Hospital in 2018 had their cases referred to the courts. Survivors may feel threatened and stigmatized and be reluctant to tell authorities about their abuse. Additionally, health centers may be poorly equipped and personnel may not have had adequate training in post-rape care or in forensic medicine. Clinics may also be difficult to access due to distance or lack of transportation, or they may completely be out of reach during times of national insecurity, such as post-election violence. Some of the financial barriers that survivors face include the cost of transportation to and from health or legal facilities, and even if they are able to transport themselves, sometimes they're asked to print documents at the police stations or pay for gloves for their forensic medical exams, which can all be prohibitive to a survivor moving through the process. There are 2 main existing sources of data on sexual violence against adults and children in Kenya. These are the Demographic and Health Survey and the Violence Against Children Survey. This data is helpful in providing some foundation, but it is limited. Neither survey collects information about the specifics of the violations, such as the time or location, and the DHS also uses a modified version of the conflict tactics scale to ask respondents about if they had experienced violence. The problem with this is that this list excludes some type of violent acts and may mean that some respondents who are experiencing violence do not report it. Additionally, as previously mentioned, violence is highly stigmatized, and we know that fewer than 2/3 of the people who should be completing the intimate partner violence module actually complete it. We had a few goals of this research. Firstly, we wanted to evaluate patterns of violence and sexual violence cases during lockdown. We wanted to study associations between patterns of violence and lockdown factors, to respond to President Kenyatta's call to investigate rising numbers of SGBV, and to produce a policy document to aid in policy change and inform actions in future humanitarian crises. Because of the pandemic, my PhD research was forced to come to a pause due to the restrictions on international travel. As a result, we used this opportunity to prospectively document cases and see whether people were able to access vital GBV services during lockdown. Knowing what we did about the depth of questions asked by the DHS and the Violence Against Children survey, and the stigma that prevented respondents from being forthcoming about the violence they've experienced, we worked with the Wangu Kanja Foundation for this project. The Wangu Kanja Foundation has representatives in all 47 counties in Kenya that work with survivors of sexual violence. Wangu also started the Survivors of Sexual Violence in Kenya network and created a mobile application that collects data about sexual violence incidents throughout the country. Because the government does not routinely gather data about sexual violence, the Wangu Kanja Foundation holds more information about sexual violence than any national survey that has been conducted. Their work was especially important during the pandemic, as resources were limited and there was widespread confusion about whether or not seeking services was a lockdown violation. The data used in this study was collected by members of the Survivors of Sexual Violence in Kenya network or associated gender defenders, and included detailed information about survivors and perpetrators and information about where and when the incidents occurred. This approach of survivors interviewing survivors helped to remove some of the shame and stigma that often prevents people from being truthful about any violence they may have experienced. For our data collection, we had a WhatsApp group that was used for communicating about new incidents, and then incident reporting was put in the WhatsApp group, and gender defenders that were in the region where the incident was reported would go talk to the survivor and collect information. Our interview protocol was informed by WHO guidelines on sexual and gender-based violence research and included safety measures developed by the research team. An example of our data collection form can be seen on the right half of the screen. Due to the urgency of the situation, we analyzed the first 100 interviews and immediately published a report and policy document in response to President Kenyatta's call. In this report, we concluded tentatively that new patterns of violence seem to be emerging. We found that the emergency measures enacted during COVID-19 seem to be amplifying women and girls' vulnerabilities to sexual and gender-based violence and preventing their access to life-saving services. According to the Violence Against Children survey, existing data taken in the years before the pandemic found that the mean age of children reporting sexual violence was 16 years old. However, our data taken in the first few months of the pandemic found that the mean age of children reporting was 12 years old, a decrease in mean age by 4 years. Additionally, data taken from the Violence Against Children survey before the pandemic found that 27% of children reported a neighbor as the perpetrator of sexual violence. However, during the pandemic, that number increased to 42%. Similarly, before the pandemic, 20% of all incidents occurred in the perpetrator's residence, but our COVID data found that 65% of incidents were happening in the perpetrator's residence. This can be attributed to repeat instances we saw where neighbors would offer educational assistance to the children in the form of internet and computer use in their home, and would take advantage of the situation and abuse the children. For adults, there is no existing national survey data about the location or time of day of attacks, but our research found that most adult victims were women. 41% of attacks occurred during the day, 39% involved multiple perpetrators, 47% were in a public location, and 50% were attacked by a stranger, whereas before the pandemic, 10% were attacked by a stranger. One possible explanation for this is that due to the national lockdown, a woman on her way to work might find herself alone on the street, whereas before there were other people around to offer some protection. For my PhD work, I was supposed to go to Kenya to conduct in-person qualitative interviews with survivors, medical professionals, and legal professionals. Due to the pandemic, I had to change the direction of my PhD and decided instead to analyze patterns of violence in these sexual violence cases that were collected, comparing adults versus children. After we published the preliminary report, we continued with data collection and ended up with more than 900 cases. After exclusion because of missing predictor variables, we ended up with 514 cases, 224 of which were children and 317 of which were adults. This represented cases from all 47 counties in Kenya. Based on our literature review, we predicted that there would be more women and girls victimized than men and boys, age-related differences in the locations in which violations were occurring, and that children would be at a greater risk than adults during the day, especially in private as compared to public locations as a result of the school closures. For our logistic regression, we used age group as the dependent variable to determine which offense characteristics significantly differentiated the child and adult groups. To determine which variables to enter into the model, we used Pearson's chi-square test for association. The variables we found were female survivor, daytime attack, private versus public location, multiple perpetrators, and known versus stranger perpetrator. This table on the screen displays the binary variables that were selected as predictors in our model. These included female survivor, male perpetrator, time of attack, location of attack, type of private location, if there are multiple perpetrators, if the perpetrator was known to the survivor, and the relationship between the perpetrator and survivor, such as neighbor, family member, or acquaintance. These tables present a more detailed descriptive analysis of the child and adult cases on the relationship between the perpetrator and the victim, and the locations in which the attacks took place. As can be seen on the tables, age group was significantly associated with the relationship between the perpetrator and survivor. Children were most often victimized by neighbors, followed by strangers and family members, whereas adults were most often victimized by strangers, followed by other types of perpetrators and spouses. Age group was also significantly associated with attack location. Children were most often attacked at the perpetrator's house, and adults were most often attacked in public locations. We also found that children compared to adults were less likely to be female and less likely to be attacked by multiple perpetrators. Children compared to adults were also more likely to be attacked in a private location by a known perpetrator and in the daytime. Our model was able to correctly classify 78% of cases perpetrated against adults and 44% of cases perpetrated against children. We also found that the age of children in our sample was 12. As previously mentioned, the nationally representative samples pre-pandemic had the average age of children as 16. Because schools were closed and there were no other safe spaces provided, children may have been left alone or under the care or supervision of neighbors, which may have made them more vulnerable to attack in some instances. Additionally, the proportion of boys in the children's group was larger than the proportion of men in the adults group. This may reflect differential rates of victimization for men compared to boys. Another possible reason is that sexual violence against men compared to boys is disclosed less often. This might be because the legal definition of rape in Kenya requires vaginal penetration, which reinforces the idea that men cannot be sexually victimized. There are a few limitations to our study. One is that we can't make national inferences because we don't have representative data, because the data we have is from people who are actively seeking out help. We also don't have information about the trends because Kenya does not have longitudinal information about sexual violence. Finally, we can't evaluate patterns of violence because of a lack of existing in-depth information about violations. Some strengths of our study is that the research was conducted in partnership with frontline survivor-led organizations using a prospective study design. This enabled us to systematically and rapidly study sexual violence in Kenya during the pandemic, even though there were considerable physical distancing measures in place. We have a few recommendations based on our research. One is that there should be inclusive, integrated, and multi-sectoral SGBV prevention and protection that is central to the government's emergency and recovery plans at both national and county levels. Additionally, there should be safe spaces offered for children if schools have to close in the future. and first responders should be trained about how to identify and report cases of violence against children. There should be routine data collection to inform prevention and protection policy, structures, and mechanisms, and real-time data collection should occur to identify geographic clusters. Medical and legal services should still be made available, and accessing them should not be in violation of curfew. Additionally, bystanders who are aiding survivors should be exempt from prosecution for violating lockdown. Innovation and technology should be used to support survivors through the referral pathway. And finally, age-appropriate awareness messages about sexual and gender-based violence should be given to children. The outputs of our research so far have been the report, which we published on the left that I spoke about previously, a perspective piece on children's vulnerability to sexual violence during COVID in Kenya, and a journal article about patterns of violence against adults and children during the COVID-19 pandemic. Thank you.